Hello and welcome to today's webinar, Enabling Quality Management Beyond Reactive HEDIS Regulatory Compliance. Before we get started, I'd like to announce a few brief housekeeping details. Today's session is being recorded, and an online archive of today's event will be available a few business days after the call. You will receive an email from AHIP that will ask if you would like to receive the archive. Please respond to the email if you would. I'd like to remind you of AHIP's antitrust statement and ask that you reference it at the bottom of your screen. The antitrust statement prohibits us from discussing competitively sensitive information. Please keep in mind you may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and then click Enter. If at any time you are having trouble seeing or hearing the presentation, please press F5 to refresh your screen. We're very fortunate to have with us today Jeffrey Springer and Frank Ingari. Jeff drives the product management and strategy in various areas of healthcare, from payer to provider, clinical to financial, analytics to transactional at HEDIS Tech. In his over 18 years of healthcare industry experience, Jeff has worked with leading healthcare technology vendors, including Siemens, MedDecision, McKesson, and CareScience. He also founded the first payer-provider contract management company in the country. Jeff holds a mechanical engineering degree and an MBA from University of Pennsylvania, the Wharton School, where he graduated as a Palmer Scholar, top 5%. Frank Ingari has served the consumer, healthcare, and information technology industries for the past 35 years and has been part of governance and leadership teams in 5 IPOs. As CEO at Essence Healthcare, he led the first Medicare Advantage plan to achieve 5 stars without owning a physician network. Also co-founded best-in-class value-based care service provider Lumeris before moving on to lead collaborative network Navinet. Frank graduated from Cornell University, concentrating in American literature and American foreign relations, graduating summa cum laude. He is a member of the board at BMC HealthNet, a top 10 managed Medicaid plan, and serves on the Presidential Advisory Board of the Berklee College of Music. At this time, I'd like to turn the floor over to Jeff.
Thanks very much, Catherine. This is Jeff. Privileged to have Frank here today to cover trends and things that are going on within the regulatory environment, HEDIS and extended. Our agenda today is, first, we're going to cover some of those trends, what's driving quality, what's driving the industry, what's driving change there, and then we'll get into a HEDIS Tech perspective around what does comprehensive quality management mean, and what are the strategic imperatives as you address some of those industry drivers. We'll then get into technology. What are some of the tenets and solutions that you must have as you build your strategic approach? And then we'll talk takeaways and answer some of your questions. With that, I'd like to turn it over to Frank, and we'll start with the industry trends and 2019 quality management impacts.
Hey, Jeff. Hi, this is Frank Ingari. Nice to be with you today. If you look at slide 3, you might be surprised to see Medicare Advantage showing up at the beginning of a HEDIS presentation. There's a reason for that. In my work with some of the major payers in the country, what you're seeing is that phenomenon underway in which Medicare Advantage and private form of care has moved really to the center of strategic conversations and investment in many, many plans in the country. And there's a reason for that. But the main reason that shows up in today's presentation is that Medicare Advantage utilizes quality measurement in a more profound and central way than we've ever seen in healthcare before. It is itself a phenomenon of tremendous revenue implications. Fargo recently predicted that it would grow $400 billion in new Medicare Advantage premium growth, and this is on the foundation of a $900 billion managed care industry. So clearly a gigantic opportunity. Meanwhile, there's some pressures on the traditional leading source of profit for insurance, which is the large group business for large employers and unions. With the rise of cost share, this has become much more of a competitive business and looks more like a third-party administrator market in some ways, with margins shrinking. And so Medicare Advantage is moving to the center as a most reliable, most predictable, and quite lucrative source of profits for profit-based insurers and surplus for the nonprofits. The Medicare Advantage business, as I mentioned, driving a shift to value-based reimbursement, and doing so in a way that's based fundamentally on quality management in all the aspects of the triple, as to say, cost management, clinical results, and patient experience. It's also important to note that the techniques and skills that you use to succeed in Medicare Advantage wind up being the core success criteria in all of the other markets, especially in government markets. So the reforms that are being proven and tested in Medicare Advantage are quite rapidly being used by CMS in other marketplaces. We see, for example, MACRA and MIPS, which are both very targeted implementations of successful metric systems from MA being moved over into fee-for-service Medicare. And I can say that in managed Medicaid, the emergence of ACO-type models becoming very important around the country, starting up in Massachusetts, again, based very much on MA-style risk adjustment and so on. Another important point about the way that MA depends on quality measurement is that it's demanding that payers build their IT systems with a new kind of a requirement, and that is that they evolve and adapt every year to respond to that CMS moves the goalpost. Every year, as star ratings achieve a kind of a star average across many, many health plans, CMS takes that one for granted, moves it aside, and brings in a new, more challenging metric. In a sense, Medicare Advantage is functioning as a continuous learning and continuous improvement system for the marketplace. This has created quite a new situation in the health insurance industry in which established incumbents are facing new disruptors who are coming into the market in pursuit of this very lucrative opportunity, and the sort of secular driver, which is that you've got 10,000 new people aging into Medicare every day. These incumbents oftentimes are very large payers who have multi-product line businesses, and in which government markets have grown up as kind of the kid brother, kid sister to the big commercial plans, and have been somewhat in a sideline position. And this has happened in a way that many times the organizations which have supported quality measurement in the past have been seen as kind of a checkbox or a regulatory requirement. So you wind up oftentimes with siloed organizations in risk and care management, HEDIS and STAR. That's not working for many, many plans because what the disruptors are able to show is that by having a much more central form of quality management and quality measure management, you are able to connect all the parts of the initiative in a way that can be very much more satisfying to providers and to patients.
So one question for you, Frank, around this. As we look at the stickiness of membership into particular plans, historically it's been 2.5, 3.5 years. If we look at Medicare Advantage, is that sticking at those numbers, or because plans have to engage more with their members, are they seeing a different adoption curve for Medicare Advantage plans? And then how does that affect for these disruptors that come in who can then take the population, the ability to transition back?
It's an excellent question. So the stickiness is very good, and it's gotten better. So in the early years of MA, there was a lot of plan switching. It has declined now. So what that does, however, is less important than it might seem because of this new entry. The fact that you have 10,000 people aging into Medicare every day. So there's a new market opportunity every year for the next 10 or 15 years as the baby boom ages in. And the disruptors are oftentimes focused on those brand new members coming into Medicare. But if you get the members and you do a good job, you're able to keep them for quite a while. So how this relates to the HEDIS landscape is kind of important, because it turns out that MA depends largely for its clinical quality measures on the HEDIS data set. So we now see this shift, which has been happening gradually in many product lines, from HEDIS and quality measures as important but related to P4P or contractual base level requirements. Suddenly HEDIS is moving into the core activity and the core strategy, because quality measures, as they feed STAR, have a kind of impact that's very different from surplus payment or a bonus payment. In fact, a STAR rating drives your ability to improve benefits, so your very fundamental product design, which really is at the core of how payers are going to compete. There's been an important thing happening for 19, which I know, Jeffrey, you're going to talk about today, which is this acknowledgement on the part of NCQA that HEDIS is being used and should be used in really the core element of strategy in Medicare Advantage, which is the contract. And that these alternate rules are allowing for more flexible use and a broader use by a broader set of entities, in particular to be at the heart of the contracts, not only between the insurance company and CMS, but between the insurance company and the provider organizations.
That's interesting. So these adjustment rules that HEDIS has introduced, it seems like they're recognized industries using these, but they had given guidance. So now they're saying we want to make sure there's consistency, and they're giving guidance on how to use it in all ways.
This is what this is doing. I'm sure folks on the phone are seeing this, that HEDIS is getting more and more attention inside their organizations, and people are realizing that HEDIS activities are both more strategic than they might have been chartered to be in the past, and that they run across more and more contracts going forward.
Okay. So with that, what we're going to do is we're going to try and involve the audience, you guys, in some of this. And we've got a polling question for you. And Catherine, if you can bring up the question here to see what your reaction is to these new adjustment rules. Our question is, how does your 2019 HEDIS strategy include these quote-unquote new adjustment rules in your execution of other things, so year-round chase, P4P, value-based contracting? So as you answer that question, we'll continue on, and we'll do a slide here and then look at the answers to that question. So next we're going to go into the comprehensive quality management section. And in this, really, we see this as things that build on one another. So the way you read this slide is from bottom to top. So clearly it starts with regulatory compliance. As Frank talked about, that regulatory compliance could be towards particular programs, HEDIS, STAR. There are other programs out there. There are clearly regulations around those. You have to certify your measures. You have to be able to collect charts. You have to be able to do abstractions, submissions, so on and so forth. That's the base of Maslow's pyramid. That's the base of this. As you go up a level, and this gets to some of those Medicare Advantage concepts talking about, is you have to make sure your scores are good. Closing gaps, being prospective about that across programs. Frank talked about the silos that are created. How do you coordinate STARS, HCC, HEDIS, provider contracts, custom measures, and the chases around that? So a provider doesn't think you're up 2, 3, 4 times. As those disruptors come in doing that, and as the sort of incumbents, you have to figure out how to coordinate those different programs, those different chases, and be prospective about it. HEDIS today, HEDIS season is after the regulatory reporting year. With those adjustment rules, I think HEDIS is strongly signaling, NCQA is strongly signaling, let's be proactive about that. How do you do that? Then moving beyond just single programs. So as Frank talked about, folks are siloed. So I've got a HEDIS group, I have a STARS group, I have a risk group, I manage my provider network. how do you manage those in a coordinated fashion? So when you're going out and talking to providers, typically we see payers coordinate around a measure. So this person's going to go and chase this measure, or around providers. So I've got pods that chase these set of providers, or around members. How do you coordinate those things so that your risk folks know what your HEDIS folks, what your STAR folks are doing, and when you go talk to a provider, it's with one voice. And then as you get to the top of this chart, it's really integrated performance management, driving innovation. So how do you work closely with providers? Providers are being moved towards value-based care more and more. These programs are driven by value-based care. How do you do that coordination so that you're in sync with your providers? How do you do real-time data collection and closing of gaps, not retrospective? So the concept of CHASE is by definition retrospective. How do you be prospective about that? There are tons of processes, workflows around fee-for-service payments today, claims. Providers call it revenue cycle management. Those processes are maturing around the quality pieces as well. So this is the pyramid that we go through as you look to improve comprehensive quality, the tiers that we look at. Now with that, let's go back to our polling question. And Catherine, if you can bring up the results for this. I think these results are actually very interesting. And I'm expecting, frankly, more no's. So we've got 68% of the folks who said their new adjustment rules are part of their strategy, and 32% said they weren't. So that's actually really great news, and it shows that people are starting to think more strategically around this. And Frank, would you think that that number was higher than you expected, or?
Yeah, it's a little higher. There may be some bias in people that show up for a webinar like this. So we're glad you're on the call. Some like-minded folks. That's a great sign, and hopefully they're being in part of the contracting strategies we're using.
Yep. And so with that, we're gonna go to our next polling question. Our next polling question is around how do you use your quality programs around this? Do you use custom measures specific to your member population or provider network to manage quality performance? Are you using some of the metrics that you're low, pushing those into contracts, pushing those into care management programs, providing holistic reports around those? So while the audience answers those questions, we'll continue from where we were, and we'll start talking about strategic imperatives for quality management. Now, as we think about strategic imperatives, it's not a yes-no question. It's more of a maturity question. So we've broken this down into 5 specific questions. You can see those on the left side of the page. Do you have an efficiency problem, coordination problem? Do you have a timing problem, a focus problem, or an outcomes problem? And for each of these problems, we create a maturity model level 1 to 4. And so to fit on one slide, we didn't fill in all the blocks of this, but to give you a sense of what they are. So I'll talk through each of the problems one at a time, and what does it mean to be at level 1 or level 4. For the timing problem, I'll throw in one in the middle, just because I think there's a clear mid-step there. So for the efficiency problem, are you really creating individual program strategies? So do you have a program for HEDIS, and then another one for STARS, and then another one for risk, and then another one for care management, so on and so forth, versus are you coordinating those programs? Are you coordinating the engagement of providers, of members? Are you coordinating the chases? Are you strategically thinking about how to create that engagement to improve scores? So level 1 is strict silos. Level 4 is coordination across all of those. As we talk about the coordination explicitly, we're talking about the types of campaigns you have here. Do your campaigns focus on a measure, a provider, and you're going to go hit up that provider for just that measure, whether it's, hey, I've got these members and I want to collect charge for them, or talking about their scores, versus a single contact for a provider to say, Here are the 15 measures we're going after. The members you have to schedule. Here's your metrics, how you're performing. Clearly, the left side, level 1, is you're having an engagement around a single question, and the right side is a single contact for all engagement. Then from the third question, the time and date problem, is how often you run your data. So as we all know, claims are slower than the clinical processes. Payers are collecting clinical data and using it at the same time. How often are you running your data out to providers? Are they complaining that they've already sent that or that's old news? And so level 1 here is you're running once a month or even less frequently than that. And then and that level 1 would be probably claims only, so not using clinical data. As you move to level 2 and 3, it's injecting some level of clinical data into that. And then as you move towards level 4, you're running daily, incorporating clinical data from your providers. And I might be talking about standard supplemental as well as non-standard supplemental data here. Then from a focus question of what do you want those scores to be, clearly I've talked about the coordination across the programs before, but as you talk about provider scorecards, engaging providers not just based on a program, but where you want those providers to be, how you think strategically about those providers, and creating really a combined score for these programs, not just an initiative around a particular measure or a particular outcome. And this gets to that outcomes question. Are you measuring just the measures, or are you measuring really risk? And risk is a big word. It's only 4 letters, but as a 4-letter word, it can mean multiple things. Is it risk around cost? Is it risk around other clinical events, visits, mortalities, morbidities? And how do you create operational and clinical engagement with those providers to help them understand that? Providers don't have as much money as payers. They don't have as much data as payers, and payers really can help providers to understand their populations, their panels better across these things. So as before we look at the next level of this maturity model, let's go back to the poll that we asked and look at the results of this. Wow. So here we're seeing 82% of folks are using custom measures to drive their specific membership. So, Frank, I think I have to agree with you. This audience is definitely the proactive audience. We talk about proactive HEDIS. This is the proactive audience. In the world that I see, it's probably not that high. So that's great. And I would have loved to have a follow-up question of what types of custom measures. You and I will have to imagine that story, but I think that's a great number and very encouraging to see that people are managing not just the regulatory programs, but towards their strategic initiative.
But also, so for the remainder of our webinar, it's going to allow us to talk at a bit more sophisticated level because we've got an audience that is with us on the use and the importance of these things.
Clearly, they've bought into the concept of thinking about this strategically to some extent already.
Absolutely.
And let's see how we can help them to accelerate that vision. That's great. So as we accelerate that vision, and I would hope that that means that the folks on the phone are not operating at a level 1 here. This is turning that maturity model on its side and talking about what do those levels look like. So I talked around a lot of this already. Level 1 is more of a tactical, level 2 semi-coordinated, level 3 clinically coordinated, and then level 4 is an enterprise clinical coordination. And as you can see here, there's data questions related to this, there's timing questions, there's coordination questions that relate to all these. So basically bringing in all of the previous questions. And as we work with payers, what we see is they focus on one thing at a time to increase the maturity of that. So I want to collect data from these sources, structural for my supplemental data, and then do that. I want to start running that data weekly. We see many payers running their data monthly. They're moving to weekly. Even some of our customers moving to daily as they do that. So as we go from level 1 to level 4, it's a coordinated effort of collecting additional data and then using that data to get better answers faster, and then to start to engage providers in a coordinated fashion. And so I'll let the audience read this over, but Frank, I don't know if you have any specific examples of different payers at different levels here.
Yeah, it's without getting to names, it's fascinating that one of the reasons why so much investment money is flowing into the Medicare Advantage disruptor space. So where, for decades we hardly saw a new insurance company. All of a sudden you see a lot of activity, not only in payers but in MSOs and so on. It's because if you focus strictly on Medicare Advantage, you can enter the market very much closer to level 4 than you would think by having a blank sheet of paper design. And so what this means is for incumbents, for very well-established plans, they've got to figure out how to move left to right very quickly. There's two dimensions that I would raise. One is that there's tremendous pressure on IT organizations to try and figure out how do I move left to right here quickly. And secondly, that the timetables that it takes to move that kind of connectedness, not only of data, which is a big issue, but also of workflow, that timetable winds up becoming critical to the contracting department's ability to move the relationship forward with providers. And you have lots of different contracts, they have overlapping time frames and so on. So it's creating tremendous pressure inside the established incumbent payers and tremendous opportunity for disruptors. So it's putting there's a lot of yield on how quickly you can help your company move from left to right.
Yeah, so Frank, you had told me this story before. It's one of the stories that I actually really enjoyed hearing you say when you were at Essence Healthcare, how you said there weren't silos. And so maybe you can talk about that.
So Essence, for those of you who don't know, is the #1 MA plan in Missouri. We grew that from 8,000 members to 60,000 members in 5 years, which was quite a ride. And when I first started consulting later with large insurance companies, it was striking to me how different it was, because at Essence, the actuary was next door to me. The chief actuary was right next to the chief medical officer, was right next to the customer support. The customer support folks were outside my office. I could literally hear if there was a problem with the patient. And so we didn't...
Is that PHI?
Yeah. I didn't really know that you could get that siloed, as you see in a $20 billion, very large payer. But, and it gives us certain advantages.
Yeah, and that's great context. So as we think about those disruptors coming in, how they're operating to that advantage. All right, so with that, we'll talk about one question here around one of the maturity questions on frequency of your HEDIS measure outputs. Are you running these things daily, weekly, monthly, or we'll put the fourth bucket here as more than monthly, because I've heard of some payers running quarterly or things like that. So treat it as D is more than monthly as you answer this question. So Catherine, if you can post this question, and then we'll continue moving and we'll come back to the answers on that. So as we talk about technology tenants and solutions, really there's a few that we want to highlight and talk about. So the first one we just asked a question about. I'm going to start top left, then make my way around this circle in a clockwise fashion so you can see what I'm talking about here. So speed of business. What is the speed of business is a very important question. How often you want to be engaging with providers? How often are you getting data in? Having your technology keep up with that speed of business, whether it's daily, weekly. I'm hoping 5 years from today we're sitting on a webinar talking about real-time and proactive. But that's the question that you have to look at and make sure that you have a solution that can run at that speed of business. Next is a one-stop shop. So we started asking questions of, do you use custom measures? And there was a resounding yes to that question. Are you looking to use those adjustment questions? About 2/3 of you said yes to that question. Do you have one set of strategic tools to help you with your standard base of that Maslow's pyramid, HEDIS stars, but also these custom rules, the adjustment rules, things like that? Therefore, you need a rules management approach to how do you build these things strategically, how do you audit them. So as these rules become the payment of healthcare, audit becomes incredibly important, and auditing the rules management, the rules execution will become incredibly important. The ability to change over time. Frank said this quickly, and I think it's important to highlight, Medicare Advantage changes every year. They look and say, hey, this is what the industry does well. Let me throw that away. Let me bring in something that can do well. So change is standard, and platform to adapt to that change. And as your networks, your members, your employers, providers, what are the things that you want to drive in order to improve that quality? And that's what Medicare Advantage is all about, is that ability to adapt. And then a contemporary solution for MRR. So everybody here knows about HEDIS season. HEDIS season is post the reporting year. How do you do chases not just during HEDIS season, but year-round, not just for HEDIS, but for all these other programs, custom rules, contracts, things like that. And then support for all the quality rules. So as we, before we move to the next slide, let's look at our poll results. We'll see here that large majority of folks are running monthly, so 81% running monthly. We have a smaller percentage running weekly. I'm actually very happy to see that nobody's running more than monthly, either that or they're not copping up to it, although I've talked to a number of payers who are, in fact, running more than monthly. And then 0 running daily, although that means some of our customers are not attending this webinar. We'll have to do a better job getting them to it. But that's interesting that most people are at that monthly level, and that's what we see is a monthly folks pushing through. So as we focus now, we're going to focus on one question here, which is the contemporary solution for MRR, and we'll go through 2 of these questions in a little bit more detail here. And as we do that, before we go through our content, we have another polling question here. So how many ways do you collect member/patient charts today? Is it during the MRR HEDIS chart chase season? Is it for risk, for claims, for other purposes, maybe contractual rules, care management, so on and so forth? So the answers are once, only for one program, HEDIS MRR. Do you do it for 2 separate programs together? And we're asking this question out of the same tool set. So HEDIS risk, do you do it for 3 separate programs, HEDIS risk utilization or care or claims? And the fourth is we have a single strategic solution for all. So as you guys answer that question, I'll go on to talk about medical record review and the different ways that we see people collecting data and strategies around collecting data. So really see 4 strategies today, and it's in terms of maturity, whether you're doing 1, 2, or all of these things. So clearly you can create a provider portal strategy for providers to enter their data through either available solutions, i.e. a Navinet and Availity, or through their own portals to communicate with providers of their gaps and allow them to enter additional data. Second strategy is through standard supplemental. So this comes in clinical formats, your HL7s, your CCDAs, your QRDAs. We can acronym you to death here, but that has a lot of good value. And how are you thinking about that? So that I actually just talked to yesterday said they'd say whatever clinical data you got, and then they end up inundated and not able to consume all those different kinds. So do you have a strategy around standard there? Then non-standard data abstraction. This is more of your standard HEDIS chase, your chart chase, using abstractors. It's an expensive proposition where nurses are typically involved, and you have your overreads that are involved there as well. And then you'll have, even in that non-standard chase, you have the ability to automate some of that. So natural language processing, text mining to answer the question first. So these are all different things that we see, and in your MRR, these are some of the things that you should look in order to expedite your strategies, your visions. So as we do that, let's go look at the results of our poll. And what we're seeing here is the highest one are, multiple programs throughout the year with 63%. That's great news. And then The smallest one is only once during HEDIS, with probably a little bit more on HEDIS and risk together, but 8% across 3 programs. So I think we're definitely here dealing with a much more mature audience. This is great to hear, great to see that there are that many people out there that are that mature in their processes. Trying to go to the next slide. Catherine, if you can help me out, I'm struggling to go to the slide.
20.
It was on, there we go, now I have the ability to do it. All right, it was 19, so I'm back now. Something that you did enabled me to do that. All right, so as we talk about some of those more advanced medical cases, really 3 concepts come out of this. So how do you manage your campaigns and your abstract? Ability to create flexible campaigns, so have heat of season campaigns, but then you're going to also have custom campaigns. You can have campaigns around which providers to engage, when to engage them, maybe for proactive campaigns on which patients need to be scheduled, which charts should be pulled, which metrics are interesting. One-touch chart collection. This is for reusing charts that have been collected, so not having people chase multiple times. And then from a efficiency perspective, making sure it's in the right provider. So the whole goal here is improving scores. Clearly there's a lot of money riding on this but there's also a lot of money riding on it with good clinical results, saving time processes around those. And so how do you chase where you can have the most impact, both on scores and on outcomes? So as we go to the next question, and we talked a little bit about this when we went around the circle originally, but rules management, especially for this audience, which is, it seems like a very mature audience, is managing custom rules, managing contractual rules. Rules management becomes incredibly important. And some of the key tenets beyond regulatory needs as you look at rules management are closing gaps. So what does this mean? So a rule is just a yes-no question. The patient has or hasn't had this test or has or hasn't had this result. But if they haven't had that result, what are the key attributes of that rule that help you to engage with that member, that provider in a better way? So for a lab test, what was the value of that lab test? Last time it was given, who was the provider that gave that lab test, the date that they're not going to be compliant? There's I wouldn't say a million, but definitely in the tens of questions you could ask any measure if there's a non-compliance that can then help you in your efficiency in closing those gaps. Then from a frequency perspective, being able to run these rules at the speed of business. Your rules management really can help to make sure those rules are run when they need to be run. And so clearly you don't need to run every rule every day, but as you engage and get that clinical data, running the rules that are relevant to remember around those measures that are there. So really having an understanding of what's affected can help with the programs and getting faster answers, especially as you start collecting more and more clinical data. I'm guessing with the group that's on the phone here, they're in that category. Coordination of campaigns, and so how do you make sure that when a new campaign is formed, so I have an issue with my colonoscopies, and I'm going to go out and engage with all of my attributed PCPs so they can engage with their patients, already know that the should also come in for your comprehensive diabetic screenings or whatever. So how do you coordinate across those campaigns? I already had one campaign running. I'm adding another campaign, doing that coordination, and then configuring these adjustment rules. So HEDIS has given us a name for those rules. They're now adjustment rules. to be able to manage those, to put those in tracks, to measure them, even to provide scorecards around them. And this last one should not be as auditing the rules. Health data is an ugly, nasty place, especially when it comes to combining, claims, clinical data together. How do those rules run, having the transparency into that? If you have a wrong answer, it could be a rule problem, it could be a data problem, it could be a process problem. Auditing is all around getting to the bottom of that and to be able to do that. And you could be doing internal auditing within your plan, but we know external auditors are coming as well, especially as this becomes more and more the currency of healthcare. Catherine, I know my computer seems to be not being friendly to me right now. So if you could go to the next slide for me, slide 22. Yeah, so as we think about all of these different things, having an end-to-end technology approach is important. So this the technology sort of architecture slide, half architecture, half to portray the different components of this. But clearly, reading bottom to top, you need to be able to consume different types of data. Clearly, the payer data with your claims, your network data, enrollment, but also now more and more provider data, whether it's the standard supplemental or non-standard supplemental data. Consumer data will become more and more important as we do this. As we combine those different types of data, we need to be able to manage our data strategies around this, not having siloed repositories for the different initiatives, but really mastering that data, curating it to come out a version of what's going on with that patient, provider, a program. As you go towards the collection, to need a chart chase, a medical record review, a data capture from the front end perspective. So being able to do that. And then at the top, really needing to manage your rules, your measures, your analytics, driving provider engagement, driving member engagement, and then running up the side on the right, driving that with rules management and workflow. So these are all the pieces that you put together. And if you think about that from the one of the original slides we showed in terms of that pyramid of different needs, starts with regulatory. So if you put regulatory into this, you can see how that would work. And it's other initiatives, it's other strategies, multiple chases throughout the year, your HEDIS, your STAR, your HCC, your customer P type programs. And then as it gets to innovation, becoming that proactive, how do you get answers as data really streams through this? So that becomes more and more important. And these are the pieces that you should include in your solution from an enterprise perspective. So with that, we'll talk about our key takeaways here. And so the webinar we wanted to cover was really 3 broad topics. So explaining comprehensive quality management. And I think this audience, with some of the questions you answered, I'm very pleasantly surprised of where they're starting from. But hopefully you learned about some of the different needs initiatives from what you need from a comprehensive quality program to that maturity model of giving you some direction on different questions to ask and how to get to that next level of maturity. So what we find with our customers is they go with different initiatives to try and improve their maturity, and then some of the characteristics from a technology solution and things that you should think about as you're adopting a strategic solution towards quality. And it's got to be something that can grow and adapt over time. To Frank's point, Medicare Advantage is coming, it's changing all the time, and there are other competitors who are thinking about this as one solution together.
I would just add a couple of thoughts. One is that we haven't talked much about today about the relationship between HEDIS and the physicians in the network. And one of the things we're seeing is that really accountable care, value-based care, for doctors is quite a profound shift. If you think about our U.S. healthcare model, it's always been a kind of a patient presentment. Patient presents with a problem and reacts to the problem. And what we're trying to do in value care is flip that around to a very significant and have the physician community, physician and all their extenders, understanding their population and in a proactive way reaching out and trying to anticipate conditions evolving and so on. And means is that we've got to help docs make this quite significant transition, and there's significant resistance oftentimes. It makes it hard for the physician organizations to succeed in a value-based contract, for example. And so the work that we do inside IT and operational groups inside the payers to create these quality management systems wind up having an important impact because, as I'm sure, based on the sophistication of these answers, everyone on this call knows, docs are very sensitive to bad data. They're very sensitive to the wrong measure information, and huge issue with how docs tend to be payers being out of touch from a timeliness standpoint. So this business of collecting quality data, everyone on this call is familiar with the fiasco we had in trying to adjust readmissions, change readmissions, when the data we were capturing that might avoid a readmission came 90 days after the readmission. So we've done tremendous work as an industry to bring information forward so that we could avoid a readmission in real time. And that model is really what we're all striving to do across the board. So this question, for example, of gap closures. So often what you're seeing in the industry with the lower performing plans are doing their HEDIS only in HEDIS season, and that's not very useful for closing gaps, given that the gap may have been in existence for 6 or 9 or 12 months. And similarly, if you're going to run campaigns, the worst thing for a campaign is to bring to the doctor's office a bunch of identified actions that the doctors say, we already addressed that, it's out of date, this patient has, died, and we've got to get really good at timeliness. But, it happens. Yeah. It happens a lot. That's the only thing that I would add, Jeff. We'd love to get some questions from...
Yeah, so I'll just make one comment on what you said, because it made me think of HEDIS clearly signaled they're going with the adjustment rules. HEDIS season has always been retrospective. It's after the regulatory period. And so in order to improve your scores, not just collect the data of what got done, you would have to run population health or care management or other campaigns during that regulatory reporting year. And I think HEDIS has seen that that's the case, and these adjustment rules are the signal that they're going to start getting into that more and more and start addressing it during the regulatory reporting year. So with that, Catherine, if there are any questions, we have a few minutes here to take a question or two.
All right, thank you very much. So we'll start with questions that came in during the presentation. Our first question, I believe, goes to you, Jeff. How would you manage metrics for across departments in a coordinated fashion?
Yeah, that's a great question. As metrics, and I have actually a picture on that as well, but it's really got to be coordinated because you've got clinical metrics, you've got financial metrics, you've got operational metrics, you've got enterprise metrics, and they really have to roll up one to another. So your clinical, your contractual, your corporate have to be integrated across the whole enterprise and really done with the optic of understanding how it affects different segments, because everybody always looks at different dimensions that you have on this. So how did it do for this doctor, or for this geography, or for this disease pattern, this benefit structure, and making sure they roll up is important. And as you fill in, here are metrics that could be at each of these levels, making sure the hierarchy and the stakeholders are really coordinated and not running in different directions around that. So that's a great question. It gets to, as we're talking about, really the clinical quality measures are just a subset of the total metric strategy that people would need to have around their whole enterprise and coordinate that to reach the corporate goals that you want to have around populations, around MLR, around keeping employers happy, which is where your revenue comes from.
Next, Frank. Oh, I'm sorry.
Yep, go ahead, Catherine.
Frank, how do you see Medicare Advantage business evolve in future compared to commercial and others?
Well, I think that, much more predictably. We have, opposed to the fairly chaotic of, say, the large group market, which vary tremendously from year to year and region to region. Medicare Advantage is unusual in that it is bipartisan in its history and its underpinnings. It was first passed under Clinton. It was first implemented under Bush. It was adopted and embraced by Obama, and it continues to be popular with both parties. So that's important to understand. I think what you're going to see is more recognition of the fact that intermediate corporate entities are starting to emerge. So you're starting to see not only payers and providers as a sharp line between, but you're starting to see the emergence of risk-bearing MSOs in between payers and providers. You're starting to see more and more payviders where physician organizations are taking on risk, which is going to lead to the next generation of TPAs. So I think you'll see Medicare Advantage recognizing that, embracing that, and I would say its most important evolution is, in a way, is really that it's seeping out into these other structures. So you're going to see Medicare Advantage style risk adjustment in managed Medicaid, and you're starting to see. I would be surprised, for example, if we didn't see this from Atul Gawande in the Amazon project, that you're going to start to see Medicare Advantage type structures be adopted into the corporate marketplace. I think those will be some of the more profound changes to come.
Great, thank you. And we have another one for Jeff. HEDIS adjustment rules are a newly introduced concept. How do you think this will get adopted and implemented in industry? And is there any advice on how to get started in this area?
So I think my answer is it's already been adopted, but it's been adopted in a way that payers are trying to figure out how to do things like proxy rules for year-round chase for contracts. So we hear all the time of saying, hey, let's remove the eligibility rules on year-round, or I want to change a value set, or I want to change a set of dates. I want to remove an exclusion criteria so that I can put it in a contract. So we've experienced that already with many of our customers wanting to change and alter the rules. I think what this will do is it will give guidance and make sure that the rule intent is not getting changed. And so what the HEDIS adjustment rules are doing is making sure the intent, both from a clinical and a financial perspective, and one of the things that I'm most excited about is they enable us to use clinical data to execute the same rules, and so providers can use it in their environments to execute and enable us to move more towards real time. How do I expect them to be adopted is fairly straightforward. People are going to look at how are my scores doing last year and say, oh, I didn't do well on XYZ, let me put that in a contract. By putting that in the contract, you're forced to be proactive with that and to adjust them to be executed year-round. And then you're going to start to say, I need to improve my score, do a year-round chase on this. You're going to be forced to do that adjustment. This gives guidance on how to do that. I already see payers have been trying to do that. Creates consistency across the industry. And I welcome that NCQA has gone there. because, frankly, it created confusion amongst the provider community when they get 14 different versions of a rule from their payers. And so I was talking to one provider who said that they had 7 different contracts each with 6 to 10 different rules from their payers, which sounds like a reasonable number on our contract, but when you add it up, each of their providers were then managing 72 rules. And in the world of providers, they complain enough about MIPS, which is 6 quality rules for the providers that then had 72 rules. It made it untenable for them to execute. And with the HEDIS adjustment rules, it can create some consistency and standardization to those for the providers to then engage more closely with their payer partners.
Thank you very much. That's all the questions that we have at this time. So I want to thank our speakers for that great presentation and for sharing their thoughts with us today. Thank you to our audience for participating in today's conference. That concludes this webinar. Thank you again, and enjoy the rest of your day.